Okay, so we are going live. Kindly switch on your camera, Dr. Salik.
Sir, I'm not actually in this basic. I got the link. I was in selected for advanced, so I just was.
Acha, you are viewing only.
Yeah.
So yeah, so that's fine. Then you keep your camera off. Yeah. 3, 2, 5, 6. All people are there, I think, na? Yes, 6 people are there. Okay. So we are starting now. So welcome all to this MedEClasses 4th annual quiz, and we are joined here in the on-site by a large number of pediatric endocrine people from across the country and the different regions, and online also we are joined in. And it's been an annual event, and we have two parts of this quiz. One is the basic quiz and one is the advanced quiz. So this is the basic quiz, and I'm pleased to have a number of people who have joined us. So this was a very toughly fought off competition, and we have got the finalists which are available now. We have got these people who are there. So I'll request all of you to kindly introduce yourselves. First of all, Dr. Sawar Agarwal, who is a veteran pediatrician from Raipur, and he has been involved in pediatric work for last 25 years. Dr. Sawar, kindly welcome, Dr. Sawar.
Thank you, Dr. Anurag, and good evening, everyone. I have been participating in all these 4 quizzes from the first one, and it's a wonderful event to be a part of. I have been in pediatrics for now almost more than 40 years, and we run a group practice here in Raipur, which is Azecta Institute of Child Health. And I think I would definitely like to mention here that we have been running an annual CME by the name acronym AWESOME. And that we have been doing for almost 22 years every year. And the hallmark of that activity is that it is done by self-sustained contributions and not from any outside help. And it is a one-day long activity every year. And we were very, very happy to have Dr. Anurag here on the Sunday. And it was a wonderful activity. So good luck to all my colleagues here, and looking forward to yet another exciting event today.
Thank you, Dr. Sawar. Dr. Vignesh.
Yeah, hello all. I'm Dr. Vignesh. I'm from Chennai. I'm first year PG at KKCDH, Chennai.
Okay, welcome, Dr. Vignesh. Dr. Rahul.
Good evening, all. Myself, Dr. Rahul Parashar. I am third year endocrine resident in National Institute of Medical Sciences, Jaipur.
Dr. Vigneshwaram. You're muted. You're muted.
Hi, I'm Dr. Vigneshwaran. Actually, I did my post-graduation from JIPMER. Currently, I'm working as senior resident in JIPMER.
Okay, welcome. Dr. Divya Lakshmi.
Good evening, sir. I am Dr. Divya Lakshmi from Madras Medical College doing second year DM endocrinology here.
Welcome. And Dr. Sharan.
Good evening, everyone. I'm Dr. Sharan from AIMS New Delhi, currently working as a senior resident.
So welcome all, and we will start the process of the quiz. So there are two components of the quiz. As I said, this is the basic component, and this is all part of the MedEClasses program that we have been running now for the last few years in terms of pediatric endocrinology. We started off with our workshops, then we started with our practical courses leading to fellowship, MedEClasses portal, textbooks and application. And we have e-learning videos, resources available which are accessed across the globe. There are courses which are available, which we run fellowship programs along with pediatric endocrinology for postgraduates. There are publications which are there, and our mobile application is there to help out in terms of practical management of pediatric endocrinology. So the 4th annual basic quiz was intensely fought. So few people did very well, and there were in between people were there. So this was a tough one. So of course, the quiz are supposed to be tough. Hopefully this one will be less tough compared to the last ones. So this was how it went off. So we have got Dr. Sawar Agarwal from Ekta Hospital, Raipur, Dr. Divya Lakshmi from Chennai, Dr. Rahul from Jaipur, Dr. Vignesh again from Chennai, Dr. Sharan from AIMS New Delhi, and Dr. Vigneshwaram from JIPMER, Pondicherry. So we will have in all, we will have 5 rounds which are there. So 4 rounds will be direct. The 5th round will be on buzzer. The first prize would be the basic pediatric endocrinology course. The second prize will be the adolescent endocrinology course with the app subscription. And then everybody will get a growth course subscription. All the finalists, they've already successful on that. There will also be interesting audience sizes, so you can all put in that. We have got a lot of audience here, so I request them to please don't blurt out unless asked, because that can cause more confusion in that perspective. So there are 4 direct round and 1 buzzer round. 10 marks for direct, 5 for pass. We have got excellent scorers in Dr. Vibha and Dr. Alapan, who will be counting the scores. 15 seconds to answer, and you can give only one answer. You cannot change your answer. And quiz master decision is final. So that is very clear. So we won't argue or debate on that. That is the way. There, of course, can be some exclusions in certain scenario. So we'll start off with the first round and we will go clockwise. We'll start with Dr. Savar. So this round is about making the diagnosis. So Dr. Savar, we have a 6-year-old boy with rickets. There is no response to therapy to vitamin D. Calcium is 9.1, phosphorus is 2.2. Alkaline phosphatase is high, PTH is normal. So this is a scenario, low phosphorus, high ALP, normal PTH. Somebody saw on the eye, this is there. Now I want which test would clinch the diagnosis. So first, of course, what are you thinking of and what test will clinch the diagnosis? Dr. Savar.
This looks like hypophosphatemic rickets with eye showing KF ring.
Yeah.
So it is probably a proximal tubulopathy.
Yes.
And the serum ceruloplasmin and copper excretion in the urine will clinch the diagnosis.
Excellent. So I think that was a good answer. So this would be a case of Wilson's disease with ceruloplasmin and urinary copper should have been done. So 10 marks to Dr. Savar. Next case is a 5-year-old boy with early puberty. And this is the child you can see. And there was one simple test which led to the diagnosis. So a bedside test was done. I had seen this case around 10, 12 years ago. A simple bedside test before doing anything else just gave the diagnosis. So Dr. Divya Lakshmi, this question is for you. What do you think would be the bedside test and what is the likely diagnosis?
So probably a HCG secreting tumor leading to precocious puberty. So we can go with the UPT test for the child.
Okay, very good. So we have got a child who has peripheral precocious puberty with a testicular volume which is intermediate, and that's why getting an HCG, you can do an HCG or you can do a UPT. This is what we did because it was not easily available at that point of time. So again, 10 marks to Dr. Divya Lakshmi for the correct answer. Next question is to Dr. Rahul. 12-day-old boy with lethargy, glucose is 26 and ketone is 0.8. Insulin is 4.3 during the hypoglycemia. Birth weight is 40 to 100 grams. And this is what was seen on examination. Which is the likely diagnosis and what is the likely genetic defect, Dr. Rahul?
So, sir, this seems to be a case of congenital hyperinsulinism.
Yes.
And along with that, we can see
so there is something specific there?
Yes, sir. I'm just not able to recall.
Okay, so you want to pass? Yeah, we'll
Yes,
come back to you if somebody doesn't answer. Dr. Vignesh? Dr. Vignesh?
This is Harry here, mesidioblastoma.
Mesidioblastoma. Wrong. Dr. Sharan?
The child has ear pits, so maybe Beckwith-Wiedemann syndrome.
Okay, good. And what is the genetic defect in Beckwith-Wiedemann?
15 P.
Okay.
I'm not sure the exact chromosome number.
Okay, so Alapan? Okay, so we will give marks there because it was main Beckwith-Wiedemann syndrome was to be picked up. So 5 marks to Dr. Sharan. Now we will have a direct question which is going to be there for Dr. Vignesh. A 3-year-old girl with diabetes, no DKA. Insulin is 0.5 unit per kg per day. The insulin requirement is 0.5 unit per kg per day. There is a family history of consanguinity in the family, and this is what you get on X-ray of the hand. So what I want is, what is the most likely diagnosis and what is the gene implicated there? So a 3-year-old girl with diabetes, non-ketotic, lowish insulin requirement.
Monogenic diabetes.
I want more specific diagnosis. Based on the X-ray, look at the X-ray. So,
Not able to.
okay. So next we'll move to Dr. Sharan again.
Suggestive of epiphyseal dysgenesis may be a Walcott-Rallison syndrome.
Okay, good. And what is the genetic basis? This time you'll have to give me the correct answer.
EIF 2AK3 genetic.
Good. So you again have got correct. So pass marks again to Dr. Sharan. So 5 marks again for getting this pass. Now you have the direct question coming in for Dr. Sharan. 3-year-old boy with short stature, height is minus 4.4 standard deviation. So very, very short. Weight is minus 2.14 standard deviation. This is the child. Somebody did an investigation, showed a glucose of 20 and ketone of 3.2. So ketotic hypoglycemia. Lactate is 1 millimole per liter. So now I want you to come up with a diagnosis, likely diagnosis. In this case, who is short, has a hepatomegaly, so that mark is there, there's a big liver, which is there, with ketotic hypoglycemia and a lactate of 1. So if you think of the algorithm, you will get the diagnosis right. And I want a specific diagnosis.
Sir, is it Fanconi-Bickel GST9?
Fanconi-Bickel is not really GSD9. So there's a bit of a difference. So you're committing to what?
Fanconi-Bickel.
Fanconi-Bickel. No, we'll pass on. Next would be Dr. Vigneswaran.
This is ketotic hypoglycemia with lactate elevation. It's possibly GST type 1.
This lactate is not very, okay.
Very
So,
high.
So this is wrong. Carry on. Dr. Samar. Dr. Samar?
Yeah, there is a ketotic hypoglycemia and with hepatomegaly.
Yes, yes.
Lactate is borderline raised, normal. So
So
the I mean, it has to be growth hormone deficiency.
we'll move forward. Dr. Divya Lakshmi. I want a precise answer. That's why I'm moving forward.
It's GSD 0.
GSD 0.
There's so much
Okay,
of
no.
hepatomegaly.
Dr. Rahul. Dr. Rahul,
No.
you're passing. And Dr. Vignesh? So I think we will leave it to the audience now. We have got audience here. What is the diagnosis? Yeah. Organic acidemia. Anybody else? This is a ketotic hypoglycemia with a large hepatomegaly with normal lactate. So this is classically GSD 3 or 6. GSD 9 I would have thought of, but Fanconi-Bickel is a different ballgame altogether. GSD 0 does not have any hepatomegaly. So that is also out. So this is classically those variants which have massive hepatomegaly, GSD 3 and 6 with a normal lactate. So no marks for anybody. Last question in this round is basically to Dr. Vigneswaran. 13-year-old boy with height of 132 centimeters. The weight is less. There is steatorrhea. This is what you see on clinical examination. Look at the eyes and look at the nails. Creatinine is normal, thyroid is normal, the albumin is 1.8 gram per liter. TTG is negative. LFT, RFT is normal, so other functions are normal. What is the most likely diagnosis?
Is having ectodermal dysplasia, like nails, abnormal nails.
Okay.
Is steatorrhea.
What's there in the eyes?
Eyes, there is.
Okay, and what do you see your diagnosis overall? Ectodermal dysplasia?
ectodermal pancreas, ectodermal dysplasia.
Okay, you picked up a couple of things. We'll move forward. We'll come back to you. Dr. Savar?
Is there telangiectasia in the conjunctiva?
I'm wanting the diagnosis. You tell me what are you thinking? Can telangiectasia give the diagnosis, or what do you want? What is your diagnosis?
Protein losing enteropathy with lymphangiectasia.
Exactly. That's true. That's what the diagnosis is. So this child has got bite-out spots in the eyes. He has got ectodermal nail dystrophy because of this loss of vitamins. And again, we are highlighting systemic causes of growth failure. So it's basically steatorrhea is a clue. Very low albumin is a clue. So this is lymphangiectasia. Again, very good answer by Dr. Savar. So we'll give 5 marks to them. Dr. Vibha, you can come up and tell us the score, please.
So after the end of round 1, Dr. Savar is leading with 15 points. Dr. Divya Lakshmi with 10 points, and Dr. Rahul and Dr. Vignesh has still yet to open their account. Dr. Sharan is on 10 points, and Dr. Vigneshwar is still on 0.
So these are early days yet. This is just the first round, which is there. Now we have an audience question also, which is there. The audience question is 10-year-old boy with thyroid swelling now moves with tongue movement. What will be the diagnostic test? So we'll first wait for the chat as to who will be answering on that online, and then we'll take it from our audience here. So you can all write on the chat or Q&A. Okay. So anybody here? I think now here everybody knows the answer. Yes, Dr. Ekta? Yes. So this is a case of basically this is a thyroglossal cyst. So this is something which you will be able to pick up on that perspective. Okay. So we have had the first round, which is there. Now we'll move from the other way around. We'll start with Dr. Vigneshwaram first, and we will move again in the same way. So round 2 is mostly planning the workup. So think of your algorithms here. So you have a 14-day-old child with disorder of sexual development, and there are bilateral gonads which are there. There is no uterus. So this is bilateral gonad, no uterus. There is hyponatremia and there is hyperkalemia. And the karyotype is XY. So which test will help you classify this further? So XY DSD with salt wasting. So I think that's a simple one. So Dr. Vigneshwaram, which single test will help you classify further?
Is it HCG stimulation test?
No. We will move to Dr. Sharan.
DHEAS levels.
Exactly. So DHEAS will help you classify whether it's a proximal defect or a distal defect. So 5 points to Dr. Sharan. Good answer in that regard. So DHEAS level will give us a clue. Next question is to Dr. Sharan again. We have a child with hypocalcemia and seizures. Calcium is 1.9. Phosphorus is 7.1. Creatinine is normal. PTH is 240. So you have 4-week-old boy with low calcium, high phosphorus and high PTH. What is the next investigation you would like to do?
Vitamin D, 25 hydroxy vitamin D levels.
Why?
Because vitamin D deficiency can also cause a transient PTH resistance. We'll
Okay,
rule out that first and then go for.
Very good. So PHP is very unlikely in this case. It's too early to present. So just because you have hypocalcemia, hyperphosphatemia, high PTH, you do not diagnose pseudohypoparathyroidism. You should get a vitamin D level done. So that answer is perfectly right. So 10 marks to Dr. Sharan. Next case, 14-year-old girl with delayed puberty, breast stage 1, pubic hair 1, no periods, height is 144, weight is 56 kgs, FSH is 21, LH is 12 and estrogen is less than 5. So no breast development, no pubic hair development, short stature, high LH and FSH. There is deafness. So diagnosis was established by simple biochemistry. So watch biochemical test will help you reach the diagnosis here. So there is a definite delayed puberty. So this question is to Dr. Vignesh.
So is this Pendred syndrome? So thyroid function test will help.
Pendred, it's a too late presentation. We'll move to Dr. Rahul.
Pass, sir.
Okay. So we'll move to Dr. Divya Lakshmi.
Could it be Turner syndrome with deafness?
It could be Turner syndrome, but I said that established by simple biochemistry. Without any hormonal investigation further, the diagnosis was made. So think of something like Turner. Which can cause deafness and delayed puberty. I think that's a giveaway. Okay. Dr. Samar?
Pass, sir.
Okay. Dr. Vigneshwaram?
Pass, sir.
Okay. Audience? So this is a classical one of pseudo hypoparathyroidism. You will have a similar features of mildly elevated LH-FSH level with deafness, and calcium phosphorus ALP will give you the diagnosis. So this was a question in that direction. So this is mostly for thinking. This is not, you would know, but if you think, you will maybe answer the question. The next question is to Dr. Rahul. Direct question. 14.5-year-old girl with delayed puberty. Again, no breast, no pubic hair, no periods. Height is short, weight is 36 kgs. FSH is 88, LH is 12, and estrogen is very low. Slightly similar to the previous case. Karyotype is XX. It's a good 30-cell karyotype. And blood pressure is 160 by 100. So the question is a simple test. Again, we are talking about very simple test which will give you a diagnosis. Biochemical routine test will give you a diagnosis here. So
This is an autoimmune POI, hypogonadism, and looking to be POI.
Okay, we'll we'll come back to you if it required. Dr. Divya Lakshmi.
Sir, it's a normal phenotype girl with delayed puberty with adequate height and hypergonadotrophic hypogonadism with elevated BP. So 17 alpha hydroxylase or aromatase deficiency also.
Which one?
17 alpha.
17 alpha. And which simple test will give you a clue? Blood test, simple serum test will give you a clue?
17 hydroxy pregnant.
No, that's a very high. I want the basic test which will tell you.
Electrolytes.
Yes. So you will expect what? Hyponatremia, hypokalemia, hyperkalemia.
Hyponatremia and hyperkalemia. Hypokalemia, sir. Hypokalemia.
Okay, so that's right. So this case, the main clue is hypertension. Anybody who has sexual infantilism with hypertension, think of a 17 hydroxylase deficiency, and in that case, potassium will give you a clue. So this is the correct answer from Dr. Divya Lakshmi. So 5 marks for her. I think this is a good answer, so we should give her an applause. It was a good answer. So 17 DOC high, but potassium will give you a clue. Next case is for Dr. Divya Lakshmi. 11-year-old boy, traumatic brain injury, admitted in the intensive care unit, improved with clinical management but developed seizures on day 2. Sodium is 125 and urinary osmolality is 300. Now there is a doubt about 2 diagnoses. I think you know which 2 diagnoses. The question is which test will help you distinguish those 2 conditions which can cause traumatic brain injury associated hyponatremia.
It could be either SIDH or cerebral salt wasting, sir. So fractional excretion of urate, serum uric acid levels can.
Okay, very good. Very good answer. So either you do a uric acid or a fractional excretion, that will give you the correct scenario there. So uric acid level will give you the answer. So again, perfect score to Dr. Divya Lakshmi. Next direct question is to Dr. Savar. 9-year-old boy with leg cramps. So he had leg cramps and he was weight of 24, height of 124. So on the lower side, potassium is 2.8. So there is hypokalemia which is causing the cramps. There is metabolic alkalosis. Blood pressure is 86 by 64. urinary calcium to creatinine ratio is less than 0.2. So the
Yeah.
question is, what will be your next test in a boy who has leg cramps with hypokalemia, metabolic alkalosis, and a normal calcium and a blood pressure?
Blood magnesium level.
Blood magnesium level. Okay, good. To identify
Gittelman syndrome.
Gentleman syndrome. Okay, very good. So magnesium level, then fractional substitution of magnesium. So again, excellent answer by Dr. Savar. So with that is a good answer. Before we have the scores which are tallied, we have the second question for the audience. 16-year-old girl with abdominal pain. There is a recurrent abdominal pain with seizures, hyponatremia, which is euvolemic. Thyroid and cortisol is normal. So which test will you like to do? You can put it in the chat option. So Q&A, earlier people talked about 17-hydroxylase, so other answers have been coming in. So in this case, you will like to do, so this is a case of recurrent abdominal pain with SIADH. Diagnosis here, anybody? So porphyria could be a possibility. So you should do a porphobilinogen in this scenario. So can you come up with the scores, Dr. Vibha, again?
Dr. Savar is 25 points. Dr. Divya Lakshmi again at 25 points. Dr. Rahul, Dr. Vignesh, and Dr. Vigneshwara has still had to open their score account, and Dr. Sharan is again on 25 points. So all the
So there is a tie on 25, but there are a lot of time left in the quiz. So we will carry forward with the third round. It will again start with Dr. Savar and go the other way around. Here you are supposed to plan the treatment. 3-year-old boy with early puberty, height is 106, weight is 14, penile length is 9 centimeter, pubic hair 3, testis is 3 ml. LH and FSH is low, testosterone is high, CT abdomen is normal, 17 OHP and HCG is normal. So if you think of algorithm, something is happening. What you're seeing is that testicular volume is 3 ml with precocious puberty, LH, FSH is low, CT normal, 17 OHP, HCG, everything is normal. What is the most appropriate effective therapy in this condition? And of course, you have to tell what the condition is. Dr. Samar?
So this child has precocious puberty, which is peripheral.
Yes.
Because the testis volume is intermediate.
Yeah.
And LHFSH are low.
Yes.
So and since HCG is normal, you had said,
yeah.
So it's not an HCG secreting tumor.
Yes.
So could it be a LH receptor problem, resistance?
LH receptor resistance?
Yes.
Resistance. So we will.
Mutation.
So what do you think? Resistance or something else? Dr. Savar?
I think it is LH receptor mutation.
Okay, so mutation is causing more action or less action?
It is a kind of constitutive stimulation of the receptor.
So, but what is the treatment? So now you are right in terms of diagnosis. The main question is treatment, actually. So we will come back to you depending upon the other results. Dr. Divya Lakshmi, what is your response? Dr. Divya Lakshmi, are you there?
Yes, sir.
So what is the treatment?
Could it be a Leydig cell tumor per se, sir?
No. Carry forward, Dr. Rahul.
Pass, sir.
Dr. Vignesh.
Treatment will be pulsatile GnRH to postpone this.
But the LHFSH is low. So carry one. Dr. Sharan?
For testotoxicosis, to prevent the maturation of bone age, we give aromatase inhibitors, and to prevent the peripheral precocity, we give bicalutamide, which is an androgen receptor blocker.
Okay, so absolutely right. So this is testotoxicosis. Dr. Savar was right, but the main treatment was anti-androgens and aromatase inhibitors. So 5 marks to Dr. Sharan. I think that the treatment was the main question there. Dr. Divyalakshmi, 13-year-old girl with drowsiness, sodium is 124, urinary osmolality is 130, diagnosed as SIADH, and somebody gave tolvaptan. Now with that, 16 hours, she had abnormal speech and vacant stare. So, of course, you have to tell me the diagnosis, but the marks are what will you do in this scenario?
So maybe probably because of rapid correction of acute hyponatremia, she would have gone for osmotic demyelination syndrome, leading to abnormal speech and vacance there.
So what will you do?
Therapeutic relowering of sodium is required here, sir. So we have to desmopressin or.
Okay, excellent. Excellent. Yeah. So this case definitely requires a relowering using free water or vasopressin. This is osmotic disequilibrium syndrome. We don't want a rapid correction in this case. So again, full marks to Dr. Divyalakshmi. Next case, 8-year-old girl with obesity, and you can see this girl. She is short, obese, increased appetite. There are some findings on examination which are seen there. Which treatment has been found to be effective in this scenario? Dr. Rahul. First of all, what is the diagnosis?
So Prader-Willi.
Okay, carry next one, Dr. Vignesh. See closely the figure. Maybe count the figure.
This polydactyly and pernicious appetite. So
treatment. Main the marks are in the treatment. Okay, we'll move forward. Dr. Vignesh, Dr. Sharan.
Bardet-Biedl syndrome, the treatment would be basically multidisciplinary because of the vision and insulin resistance.
Yeah. So all the other things that, but any specific drug which has especially been found to be effective. Need not be very fancy.
Metformin, I'm not sure.
Okay, metformin, it's true. So we'll give you the marks. Metformin is what we are looking at. So 5 marks to Dr. Sharan. So metformin is the drug. Next question is to Dr. Vignesh. 3-year-old girl with severe decay manages decay for 6 hours. There is pH 6.9, bicarbonate 5 and ketone 6.4. When they came to you, the potassium is 2.8 and she is dehydrated. So what will be your first fluid you will give in this case? So somebody has treated her and now comes to you with severe acidosis and hypokalemia. What is your first fluid you want to give?
fluid will be 0.9 NS to correct this 10 ml per kg or 8.5 ml per kg to correct the initial dehydration. Then
you will give the bolus and
then we'll follow up with
okay, I'm talking about the initial bolus as well. So we will move to the next option. Dr. Sharan.
Since the child has low potassium, we can consider giving in the bolus itself 1:100 kcal, 10 ml per kg.
Yeah, so 20 ml per kg is recommended. So this is as per the ISPAD guidelines. We should actually start normal saline with potassium. That is an important message in this case. So again, pass mark to Dr. Sharan. Next question is to Dr. Sharan. 4-day-old boy with seizures, birth weight is 3.2, there is asphyxia, calcium is 18, phosphorus is 4.2, PTH is less than 1, and vitamin D is 30, calcitriol is 250. So you have hypercalcemia in a setting of asphyxia with low PTH, vitamin D is normal, calcitriol is high. Of course, what's the diagnosis? But more important is how will you treat this child?
This is due to the secondary fat necrosis and the increased 1-alpha hydroxylase activity, hypercalcemia. So we give hyperhydration, and steroids can be beneficial in this because they decrease.
Very good. So that's the answer I was looking at. So this is a subcutaneous nodule necrosis, and here the treatment are steroids. So again, full marks to Dr. Sharan. Last question of this round is to Dr. Vigneshwaram. A 6-year-old boy with rickets, no response to therapy. Calcium is 10.1, phosphorus is 2.2, ALP is 1200, PTH is 32. Urinary calcium is 0.5 milligram to milligram. So we have got this scenario. Now, what will you do in terms of treatment? What is your diagnosis first? So this is a refractory rickets with low phosphorus, high ALP, normalish PTH. Yeah, what is the diagnosis and treatment,
It's
doctor?
basically refractory rickets with the hypophosphatemia. So
Yeah.
hypophosphatic rickets along with the excretion of
Yes.
urinary calcium. So
Yes.
some hypercalciuriasis, borderline hyper. So for hypophosphatic rickets, we'll supplement with that neutral phosphate.
Yeah. Only
Along-
phosphate or something else?
Along with calcium.
That is the whole question. Will you give calcitriol or not?
No.
Okay. So this is basically a case of familial hypophosphatemic rickets with a sodium phosphate hypercalciuric variant where you should never give calcitriol. That is the main message. That was the question. So phosphate alone will give you the full marks here. So it was very good. You got the correct answer. So 10 marks there. So we have finished off 3 rounds. While the scores are being tallied, we have this audience question. 14-year-old boy with obesity, developmental delay, hyperphagia, infantile hypotonia. This is a child. Which treatment improves body composition? So I think all the audience, everybody knows this is a growth hormone treatment. So Dr. Vibha, can you come up with the score after round 3?
After round 3, Dr. Sharan is leading with 50 points, followed by Dr. Sabha, followed by Dr. Divya Lakshmi with 35 points, and the third, Dr. Sabha is on 25 points, and Dr. Rahul and Dr. Vignesh had still yet to open their account.
And Dr. Vigneshwaram is at 10. Yeah. So we'll now come back to round 4 and we will start again with Dr. Vigneshwaram. And this one will no pass. This is a spot the diagnosis. You have to spot it right away. There will be no pass if you can't answer that. So Dr. Vigneshwaram, have a look at this. 13-year-old girl with backache. You can find this. What is the treatment for this condition? She has severe backache and she has been going to orthopedics and everybody.
Osteogenesis imperfecta.
And treatment? You want to increase the bone mass, what will you do? Any drug which can increase the bone mass? Okay, so we will give 5 marks there. So OI is the right answer. So this is basically OI1 and bisphosphonate therapy, denosumab, whatever you could have come up with. We've agreed. Next question is to Dr. Sharan. This is an X-ray of skull done for somebody with headache. What is the diagnosis and what is the most common endocrine manifestation of this condition?
Diagnosis could be craniopharyngioma.
Yeah.
And most common endocrine manifestations would be growth hormone deficiency.
Perfect. So 10 marks to Dr. Sharan. Excellent answer. Next question to Dr. Vignesh. 5-year-old boy with short stature. The multiple X-rays are there. You can look at the child's photo, the X-ray of the hand, the limbs, and it's very clear. What is the diagnosis? 5 marks for that. And what is the novel treatment for this condition?
So trident hand, everything is there. So
yeah.
Osteopetrosis, achondroplasia.
So which one?
Bone within bone. This is achondroplasia.
Okay, and specific novel treatment?
That I'm not sure.
Okay, we'll give you 5 marks. It's not a passable one, so we'll give you 5 marks on that. So vosoritide or the CNP receptor agonist can be considered there. Next one is to Dr. Rahul. 3-month-old boy with micropenis and inguinal hernia. Look at the face carefully. Sodium is 130, potassium is 5.8, head circumference is only 32 centimeters. Diagnosis was established by a simple biochemical test. I want the diagnosis and the test.
So,
So there is micropenis, there is salt testing,
yes, sir.
microcephaly.
So,
Any, you want to make a guess or we'll pass on from there?
no, sir.
Okay. If they're not, what from the audience? So Smith-Lemeli-Opitz syndrome, you can see the upturned nares, and lipid profile will be the simple test which will give you the diagnosis. Then question to Dr. Divya Lakshmi, 15-year-old boy with delayed puberty, small phallic size at birth, height is 162, weight is 60 kgs, testicular volume is 1 ml and soft, and there is stage 3 development. There was one neurological feature on examination that established the diagnosis.
Sir, since the testicular volume is 1 ml, it's hypogonadism, sir. So
Yeah.
probably anosmia causing due to Kalman.
Okay, can you tell me one more neurological manifestation? Some other, if you can tell? Other than anosmia?
Hearing defects can be there, sir.
Anything
Cleft lip,
in
midline,
movement? In movements, body movement?
synkinesia, sir.
Good, good. Okay, so we'll give you the marks, 10 marks here, Dr. Devilakshmi. So I was looking specifically for synkinesia, although anosmia, everything meant that you were right. Dr. Sawa, this is the last question for this round. 6-year-old girl with precocious puberty, and you can see this. What is the diagnosis and what is the further workup?
Since these are bilateral capillary spots,
Yeah.
which is not restricted to one side of the midline,
Yeah.
the diagnosis is NF1, and precocious puberty will be because of optic glioma. So MRI would be the helpful diagnosis.
Very good, very good. This is a perfect answer we're looking at, not to get confused with McCune-Albright. This is basically a case of NF1 with optic nerve glioma. MRI should be done in this scenario. So by the time we have the answers being tabulated, we have an audience question. 18-year-old girl with secondary amenorrhea, stage 4 blast, pubic hair 4, LH low, FSH low, prolactin 500, TSH 4.4. What is the next test? So who's saying MRI? So this is a girl who has secondary amenorrhea. You can see LH-FSH is low, but you have got a huge amount of prolactin elevation which is being seen there. So this is basically an estrogen will be high. So the next step should be, before you do anything, is to look at pregnancy. So if there are any answers, we'll see there. So UPT, Dr. Pamali is saying, so yes, pregnancy test should become important. So this was just the one to go forward. This is physiological hyperprolactinemia. So what are the scores after round 4, Dr. Vibha?
End of round 4, Dr. Sharon is leading with 60 points, followed by Dr. Divya Lakshmi with 45 points. Then Dr. Savar is on 35 points. Dr. Vigneshwaram has gained 15 points. Dr. Vignesh, 5 points. And Dr. Rahul is still at 0 points.
Okay, thank you. So we will now move forward to the round which is very, very interesting. Yeah.
Can you repeat?
Yes. So you, Dr. Savar is at 35 points. Dr. Divya Lakshmi at 45. Dr. Rahul at is yet to open the account. Dr. Vignesh at 5. Dr. Sharan at 60. And Dr. Vigneshwaram is at 15. So there is a small gap between the top 3. So this is next round is going to be a buzzer round, which is the fastest finger first. And we will have the chat. You have to basically say yes in the chat option to get the answer. And a test N would be written from our side. At that point of time, you have to write Y for the buzzer. And the question will stop there. So I won't ask the question any further. And then you will have to answer immediately. in that perspective. Immediate answer, no pass. We have +5 for correct and -5 for the wrong answer. So if somebody gives 6 correct answers, they can give 30 points. So Dr. Savar can go to position 1 if he answers all 6 correctly. So this is how it is. And if somebody answers 6 wrong, he will get -30. So that's fine. So this is how it should be played on that. So I think we will first of all try this, how it works. So I think you can go to the chat. So all of you are can write your Y or something on the chat. So Dr. Sharan has written, Dr. Vigneshwaram, Dr. Divyalakshmi, Dr. Rahul, Dr. Savar. Yes. So what I will do is that I will write N.
Yes.
So once I write N, now anybody who is going to write now is going to answer the question immediately. And we are not going to wait for the scenario. Are you seeing the chat in the phone as well? No. No. Okay, fine. So we'll have a look here only. So are you ready for the option? Any confusion here? Any confusion from any of the panelists?
No, sir.
No, sir.
No. And we want the answer to be immediate. We don't wait and you will immediately deduct a -5 if the answer is wrong. So be a bit cautious. So we are starting with the questions. This is again, the rules are clear. We start with the first question. 10-year-old boy with seizures, ionic calcium is, so we already have answer from Dr. Sharan. Answer? Dr. Sharan? Dr. Sharan, we want immediate answer.
GNAS.
GNAS full 1, 2, 3, 4, what?
GNAS 1, sir.
GNAS 1. So correct answer is from Dr. Sharan. So we will give him a total 5 marks. Next question. So I am again resetting it. Now you people can have be ready with your fingers ready. So fastest finger first. Next question is 11-year-old girl with recurrent fractures. There is failure to thrive, polyuria and myopathy. There is hypokalemia, hypophosphatemia. pH is showing metabolic acidosis. Urinary pH is 7. Dr. Divyalakshmi, what is your answer? What is your answer? No, I deliberately asked because she put it, na? So what is your answer, Dr. Divyalakshmi? Did you see the question? Complete question. So be careful. Don't push your this thing without reading the questions. Dr. Divyalakshmi, you are there?
Hello, sir.
Yeah, so your answer, you haven't seen, did you see the question or you just put the mark quickly?
It was RTA, sir. I didn't see the complete question.
Please don't do it in future.
Yes, sir.
But I'll just give you for this benefit of doubt. What is the impact of bicarbonate treatment on potassium in this case?
This is distal RTA, sir. So
Yeah.
correction of acidosis per se will start improving the potassium levels.
Okay, so we'll give you 5 marks there, but be cautious in future.
Yes,
Don't
sir.
answer before you get the full question. So we'll reset again. The next question, the RTA, it will improve, while proximal RTA, it will worsen. Next is severe decay on DKA protocol. There is leg pain, high colored urine. Dr. Sharan has again written Y, so very fast fingers. Yes, what is the answer?
Sir, would be to supplement phosphorus and to use instead of potassium chloride, we can use 1:1 potassium chloride and potassium phosphorus, sir.
Excellent. So Dr. Sharan again +5 in that. So we will now, so you should give potassium phosphate to prevent this complication. So I'm again resetting that. Next question, be ready everybody. So what is the, how many questions we have done till now? 3. And what is the score? So 3 more questions left. What is the score till now, Dr. Vibha? So Dr. Sharan is leading with 70 Dr. Divilakshmi is at 50, Dr. Savar is 35, Dr. Vigneshwaram at 50, Dr. Vignesh at 5, and Dr. Rahul yet to open. So I think the top position seems to be secured. There is a fight for the second position. So if Dr. Savar can answer all three right, he can be at a tie. So that could be a scenario. Yeah. So I think still the match is not over. Okay, so we will reset that and we will go to the next question. Day 10 child, TSH is more than 100, FT4 is 0.6. Dr. Savar has answered. Yes, Dr. Savar?
There could be thyroid TSH blocking antibodies.
Okay, so we should do a TRAB antibody. So again, 5 points correctly to Dr. Savar. So this is a case in which you have apparent athyrosis. So here you should do a TRAB in this setting. We are resetting the chart option again. And now we are moving with the second question. 15-year-old girl with hypoglycemia, birth weight 3200, GIR 14, ketone 1.1. There is a insulin 3.2 biochemical test that established the diagnosis. Dr. Savar?
This child has ketotic hypoglycemia. We should do a reducing substance in the urine.
Okay, but the insulin is a bit high. So this is a tricky question. There is a slight ketone is high, but not that high. And insulin is high for the level of hypoglycemia. GIR is high. So this is actually hyperinsulinism. And ammonia is what we were looking at to get a basic workup for HIHA. So unfortunately, -5 to Dr. Savar. Just before the final question, what are the standings? Same standing. So Dr. Sharan is at 70, Dr. Divilakshmi at 50, and Dr. Samvar is at 35. So I think the results are pretty much sealed now, but still the last ball has to be bowled. So let's see, we'll reset the question here. Okay, so clinodectily and this girl, most common cardiac defect.
Most
Dr.
common
Sharan?
coarctation of aorta.
Coarctation of aorta.
Bicuspid aortic valve, sorry. Bicuspid.
No. This is actually not Turner syndrome. This is Noonan syndrome. And the most common one is pulmonary artery stenosis. So we'll have deduct that -5 point there. Yeah, so that's a different matter. So the audience question finally, 28-year-old pregnant lady with SLE, anti-Ro, anti-La antibody positive, fetal heart block, steroid treatment, which preparation should be used? So dexamethasone, which can cross from there. So I think we have got the final answer rounds which are there. So the final scores, the first position goes to Dr. Sharan. He has got 65 points. So again, congratulations.
Thank you, sir.
Second goes to Dr. Divilakshmi with 50 points. Congratulations.
Thank you, sir.
Dr. Savar, 35. Very well fought. And then Dr. Vigneshwaram is at 15. Dr. Vignesh is at 5 and Dr. Rahul is yet to open the account. But remember this quiz itself, the prelims was tough. A lot of people participated. So coming here also is a very significant achievement. We will now just want to have the feedback from people before we move forward. So Dr. Rahul, we'll start with you.
Sir, actually it was a very good learning experience. And all the algorithms I have already read in your book, MedEClasses books, but actually I could not reproduce it here. So
it's often the quiz is a pressure situation, so don't worry, it's a common one. Real life, you should remember them, and the book can be seen again also in the real life, so don't worry.
Yes,
Dr. Vignesh?
So, hello, sir. Just now I have started my pediatric residency, so many things looks very tough to me right now. Also, probably a year or two down the line, I may have a good time here. Very good experience. Thank you.
Okay, great. Thank you. Dr. Vigneshwaran?
It's a good experience to participate here, but the questions are very nice to be prepared. So it's well prepared questions. We'll look forward in future for them.
Thank you. Dr. Samar?
Like every year, participation in this quiz is an exciting and excellent experience. Some of the questions very hard way came to me, and maybe But I have no complaints at all. The most worthy person has won the competition. Thank you so much.
Thank you. Dr. Divya Lakshmi?
So it was a enriching experience for us. Thanks a lot, and thanks for the classes also. So it's a good exposure to pediatric endocrine classes for us.
Thank you. And Dr. Sharan?
Thank you so much for the opportunity, sir. And I'd like to take this opportunity to thank you also, sir. Your books and your classes really helped me throughout my preparation for my entrance exams also. Thank you so much.
Thank you. Thanks a lot. So we will now be moving towards even tougher questions. So people were saying some questions were tough. So this hopefully will be the what tough really means from that perspective. Because we now have the advanced quiz, which is coming up. And so I hope that all of you have joined for the advanced quiz. I'm seeing, so I request all of you to kindly switch on your cameras, and for the other ones to kindly switch off the cameras. You can keep watching the quiz, but I want those who are for the advanced quiz to quite open up. So we have got all the people, I think that they are there. So advanced quiz again was much tougher compared to the basic one, and yet we had got very good response. The first prize will be the advanced pediatric course, the basic pediatric course, and the adolescent endocrinology course for others. We've got Dr. Kopal Paharia from AIMS, Dr. Sachin Raj, who is doing DM in AIMS adult endocrinology, Dr. Manoj Reddy, who is the endocrinologist from Kadapa, Dr. Anju Bala, who is doing DM in pediatric endo from PGI Chandigarh, Dr. Mohammad Saliq, fellow in pediatric endo
Yeah,
from
Gadi.
and Dr. Sukanya. So we will, before we start this, we will have a quick introduction. So we'll start with Dr. Kopal.
This is Dr. Kopal. I am doing my DM in pediatric endocrinology from AIMS Delhi.
Thank you.
Yeah,
Dr. Sachin.
I'm Dr. Sachin. I'm doing a DM in adult endocrinology from AIMS Delhi.
Dr. Manoj.
Yeah, I am Dr. Manoj. I am practicing endocrinologist at Kadapa, Andhra Pradesh.
Thank you. Dr. Anju.
I am Dr. Anju. I am presently doing DMSRship at PGI Chandigarh.
Dr. Saliq.
I'm Dr. Mohammad Saliq, currently doing pediatric endocrine fellowship in CMC Vellore.
Dr. Sukanya.
I'm Dr. Sukanya. I'm doing DM pediatric endocrinology at AIMS Delhi.
Okay, welcome all, and we will have an interesting round of advanced quiz. So this again has the same format. There are 4 direct and 1 buzzer round. 10 marks for direct, 5 for buzzer, 15 seconds to answer, and you can give only one answer. We'll be more strict in this one because this is for the advanced level. And quiz master decision will be final, so we will have no arguments in that regards. We'll start with the first one to spot the diagnosis, and the direct question will go to Dr. Kopal. So we'll start off with this question. 2-month-old boy with developmental delay. And what we are seeing is that there is persistent hypoglycemia with a high glucose infusion rate, around 12 to 14 milligram per gram kg per minute. Glucose is persistently low. Ketones is negative. Insulin is undetectable. Now, what is the most likely diagnosis in this setting, and which test may help you identify that?
Sir,
Yeah, Dr. Kopal.
Maybe due to post-receptor defects, post-insulin receptor defects like 8KT, and test will be molecular genetic diagnosis.
Okay, I agree with that. So this could be a part of a post-insulin receptor defect like AKT2. You can do a glucagon test, or genetics also is acceptable. So we'll give complete 10 on. So good answer there. So Dr. Kopal, full marks for this one. Second question is to Dr. Sachin. 8-year-old girl with developmental delay, sodium is 122, urinary osmolality is 180. There is no response to fluid restriction, no response to talveptin. AVP is 1 picogram per ml. What is the gene which is implicated, and what is the treatment? Dr. Sachin?
Not sure.
Okay, we'll pass over to Dr. Manoj.
Sir, this may be a nephrogenic DI, sir. maybe APP2 receptor defect in the tubule.
Nephrogenic DI.
TI.
So low.
Okay, we'll carry forward to Dr. Anju.
Sorry,
Yeah. Please, you want to correct yourself?
Yes, sir. No, sir. Like this is a SADH this thing. So no response to tolvaptan, and then this thing. No, sir. Pass on, sir.
Pass. Okay, Dr. Anju.
Sir, it is mostly due to ABP receptor activation leading to
Okay.
SIADH.
Yes.
And the treatment in this, I'm not, sir, very sure about that.
We'll give you 2.5 there. So this is nephrogenic SIADH. So there was a bit, Dr. Manoj, you just made a confusion there. This is nephrogenic SIADH. And the treatment here would be urea. So 2.5 marks will be given to Dr. Anju. Next question is, third question is directed to Dr. Manoj. 2-month-old boy with failure to thrive. Weight is 2500 grams. Height is 52 centimeters. Sodium is 130. Potassium is 6.2. Cortisol is 60. ACTH is 500. 17-OHP is 10. Testicular volume is 1. This is the imaging which is done. Now the question is, which is the gene implicated and what is the expected effect of this gene on the puberty? So you have a failure to thrive with hyponatremia, hyperkalemia, low cortisol, high ACTH, normal 17-OHP, and a prepubertal child.
This is looking like a congenital adrenal hyperplasia with
hyperplasia. Okay, we'll move forward. Dr. Anju?
Sir, it is looking like congenital adrenal hypoplasia. Gene implicated could be DAX1.
Yeah.
And hypogonadotropic hypogonadism is the pubertal effect in this.
Perfect. So this is case of DAX1, NROB1 defect and HH. Somehow Dr. Manoj is going the other way around. He's saying congenital hyperplasia instead of hypoplasia. So I think just maybe just think and you will get the right answer. You're very close to in both cases. So anyway, we'll move forward to the next question, direct question to Dr. Anju. 18-year-old girl with primary amenorrhea, and this question is a case which we discussed with Dr. Shekhar. So this is again an interesting case. Breast stage 1, pubic hair stage 4, height of 176 centimeters. Facial acne and clitoromegaly is there in the girl. FSH is 41, LH is 26, estradiol is 60. So what is the genetic diagnosis and what is the expected bone age in this case? You can give me a ballpark figure.
So, so it
just look at the figure, then you will get the result. I think it's not
aromatase deficiencies, sir.
We'll pass on. Dr. Salik?
Sir, is it CYP19A1 aromatase?
No, that's aromatase. So we'll pass on to next one, Dr. Sukanya.
Sir, it could be an estrogen receptor defect and the bone age might be delayed in this girl.
Okay, which receptor do you think? That's a bonus mark. So anyway, so which receptor? ES1. So this is a estrogen receptor defect. And this is a publication which Dr. Shekhar had done. So this is an interesting case. So high estrogen. So this is not aromatase. The estrogen is high. There is clitoromegaly because your LH is high. This is stimulating the production of androgens. So this is actually a ES1 defect with delayed bone age. It was, I think, 12, 13 years in this case at 18 years. And she was so tall. So tall girl with delayed puberty. So Dr. Sukanya has got the correct pass answer. Next question to Dr. Salik. 5-month-old boy with failure to thrive, fever, dehydration, and sodium is 163, urinary osmolality is 120. Which history in the mother gave up the diagnosis? Like it was clear with that history on mother that the diagnosis is this.
Maternal history of polyhydramnios?
Maternal history of polyhydramnios means mother, when she was in fetus, she had polyhydramnios.
No. So antenatal history of polyhydramnios.
But I'm asking something more specific. So you are in the right direction. So what can happen to the mother in this case? So what is the diagnosis you are thinking of first?
Nephrogenic DI in the child.
Yeah. So what can happen to the mother of nephrogenic DI during some particular phases of life?
प्रेगनेंसी में एग्रोवेट
Dr. Savar?
So
प्रेगनेंसी में एग्रोवेट होगा.
Dr. Savar, please, your voice is heard. So, okay. Yeah, Dr. Salik, can you get the answer now?
yes, sir, that's not it will like.
But you got the thing right. So this is nephrogenic TI. I'll give you. They
Yes.
will be. So if you can tell me why does it precipitate during pregnancy?
Sir, I'm not sure about that, sir.
Okay, so we'll give you 5 marks. I think the answer has already been given. So basically what we are looking here is that we are basically looking at a scenario wherein you have increased placental vasopressinase level, and that is why this AVP is degraded and they will develop nephrogenic DI in this scenario. So mother will develop polyuria during pregnancy. Last one for this round is Dr. Sukanya. Direct question. 3-week-old boy with lethargy. TSH is more than 100. Free T4 is 0.4. Increase uptake on scan and thyroxine was started at 15 microgram per kg per day. But after 1 month, still the TSH is more than 100. Dose was 25 microgram per kg per day. Still the TSH is more than 100. So what is the cause and how will you treat this?
Sir, if the T4 values, the free T4 values have been corrected and TSH persists to be more than 100, it might just be HPT axis reset.
Free T4 is also low. Free T4 is also low.
Sir, even on treatment?
Yes, yes. Despite 25, FT4 is also low.
Sir, could it be an MCT8 defect?
No, we'll pass on to Dr. Kopal.
Sir, it can be.
Your voice is cracking, Dr. Kopal.
Sir, am I audible?
Yes, now you're audible. Please go ahead.
Due to peripheral realization of.
Yes.
I'm not sure.
What do you call that?
Because of hemangioma, liver hemangiomas.
Good. And how will you treat it?
So treatment with higher doses of thyroxine.
You're giving 25. Anything else? Just think about it. You will get the answer. Otherwise, half of you is answer is correct.
So surgical treatment of the underlying disease. And
we'll give you the marks. The main is this is a consumptive hypothyroidism. You can give T3 therapy, which we discussed, I think, just in this group as well. So we'll give you the pass mark because this was a tough one. So by the time we are collating with this, we have our audience question. 14-year-old girl with tall stature, height is 173, arachnodactyly, upward lens dislocation, pectus carinatum, and which acute emergency is likely? Aortic dissection. Okay, everybody agrees? Yeah. So what is the answer? Now, what is the score? So you can come. Dr. So you can also be more active.
So for end of round 1, Dr. Kopal is leading with 15 points, followed by Dr. Anju at 7.5 points. Dr. Salik and Dr. Sukanya scoring 5 points each. And Dr. Sachin and Dr. Manoj have still yet to open their account.
Thank you, Dr. Vibha. We'll start with the second round, and the second round basically is imaging, and we'll start in the reverse from Dr. Sukanya. So, Dr. Sukanya, this is the 8-year-old boy with precocious puberty. What is your diagnosis? Dr. Sukanya? Dr. Sukanya, you're there? We will move to the other one now. Dr. Salik?
Is the arachnoid cyst?
Arachnoid cyst.
Sir,
Yes. Yeah. Yeah, this is arachnoid cyst. So this is the correct answer. So we'll give 5 marks to Dr. Salik. Dr. Sukanya, could you not listen to this question?
sir, can you hear me?
Yeah, now I can hear you. We couldn't hear you earlier.
Okay, sir.
So did you try to answer this question?
Yes, sir, but I think I was not audible.
So if that is the case, we can give 10 marks to Dr. Salik here. And the next question you can answer. But be sure that you are audible here. Okay, fine?
Yes, sir.
So arachnoid cyst will give full marks to Dr. Salik. And we have the second question for Dr. Salik will go to you. Which endocrine condition is associated with this finding? Yeah, Dr.
So this shows intracranial calcification, which could be as a result of hypoparathyroidism.
We are looking at more specific answer. Dr. Salik.
No idea.
Dr. Anju.
Sir, looks like multiple neural calcification, multiple cerebral calcification, sometimes in neurotuberculosis, but
In
no, sir.
endocrine. Any specific condition? This is a bit unusual for hypoparathyroidism. That's why I'm not giving the marks there. Dr. Manoj.
No, sir. Pass, sir.
Dr. Sachin.
Pass. Basal ganglia calcifications are there?
No, these are not basal ganglia. That's the point. Dr. Kopal.
I'm not sure, so pass.
Okay, so this is a cerebral calcification seen in nephrogenic diabetes insipidus. So this is a special type of form. So that's why we didn't give it for the basal ganglia, because basal ganglia is more common with pseudo-hypoparathyroidism. Next one is for Dr. Anju, direct one. 12-year-old boy with gynecomastia, and this finding, which is the gene which is implicated and what is the treatment? Dr. Anju?
Sir, this could be Peutz-Jeghers, sir, Peutz-Jeghers syndrome.
Okay, what's the gene?
Sir, I'm not sure about the gene.
Okay, and what will be the treatment?
So in this case, Sertoli cell hyperplasia leading to, sir.
Yeah, I'm asking for the drug. So I'm not talking about surgical or other. I'm talking about which drug could be effective in this specific condition. So we'll give you 5 marks. We'll move forward for the second one if somebody can tell me the treatment. Dr. Manoj?
So letrozole can be given.
Letrozole. So we will give you 2.5 because this is a half pass mark. So 2.5 to Dr. Manoj and 5 to Dr. Anju. This is STK11 problem. This is Peutz-Jeghers. It's okay. You don't know the gene is not that much important. Aromatase inhibitor is what we can look at in terms of treatment. Next question directly to Dr. Manoj. 16-year-old boy with thyroid nodule, TSH is normal, 3.4. What is the malignancy risk roughly? I want a rough malignancy figure based upon this finding on ultrasound. So how many % chance of malignancy is this?
Sir, maybe less than 5%, sir, because margins are regular. There are no calcification specs, and but the lesion is and the lesion is also not taller than wider, so less risk of malignancy.
Okay, we'll get some more options. Dr. Sachin?
Less than 1%.
Okay, we'll get more options. Dr. Kopal?
Sir, not sure. Less chances, but not sure about the exact.
Okay, Dr. Sukanya?
Sir, again, not sure. It looks more benign, but not sure of the
Okay, Dr.
malignancy.
Salik?
Sir, around 10 to 15%.
10 to 15%. What are you seeing here which says 10 to 15%?
Sir, it was a blind guess. Now much
Blind guess is right.
calcifications are visible.
So it's not a very high risk, but it's not a very low risk as well. This is around
Yes.
10 to 20%. So this is a good answer. So Dr. Salik is the correct one. He'll get 5 marks for the past one. So the next question we have done till Dr. Manoj, and now direct question for Dr. Sachin. 12-year-old girl with short stature. This is the X-ray finding. What is the diagnosis and what is the most effective treatment? Yeah, Dr. Sachin?
Sure. Advanced bone age,
No, what is the diagnosis?
precocious puberty.
No. So next, Dr. Kopal.
Sir, looks like mid-lung deformity. So shocks, mutation.
Okay. And treatment?
Treatment would be growth hormone in this
Sure.
case.
So this is correct. 5 marks for Dr. Kopal for the correct option. So this is basically a shocks defect with growth hormone treatment as this thing. So Dr. Kopal will get 5 marks. Now the next question is a direct question to Dr. Kopal. A 12-year child with short stature, and these are the findings we are seeing. What is the diagnosis and what is the likely genetic defect? So Dr. Kopal, what do you think?
Sir, is it
Very short.
Ptosis? I don't know, maybe
So what
because
did
of
you
the
say?
stuff.
So what did you say? I couldn't get it. Can you say come again?
Pycnodysostosisis, sir, one form of skeletal dysplasia. I'm not very sure, sir.
So you're saying pycnodysostoses. Yeah?
Looking at the fingers, stubby fingers, and sir.
Your answer is right. What is the genetic defect?
Genetic defect, I don't remember, sir.
So we'll give you 5 marks there. We will check if somebody comes with genetic defect for 2.5. Dr. Sukanya?
Sir, cathepsin K.
Yes. So Dr. Sukanya will get 2.5 and 5 to Dr. Kopal. So we have completed 2 rounds and we have our audience question again. 6-month-old child with failure to thrive, pigmentation, hepatomegaly, hyponatremia, hyperkalemia, and this is what you find on the X-ray. What is the diagnosis? So what are you seeing, audience here? So there are calcifications there. At which area? So Dr. Savar is asking Woolman syndrome. Correct. So there is an adrenal calcification and Woolman syndrome. So that's a good answer. So we will now probably go ahead with the scores at the end of 2 rounds.
At the end of round 2, still Dr. Kopal is leading with 25 points, followed by Dr. Anju with 12.5 points. And then Dr. Sukanya is scoring 7.5 points. Then Dr.
Salik is at 20.
Sorry, I would like to mention Dr. Sadiq is on 20 points, Dr. Sukanya at 7.5 points, Dr. Manoj at 2.5 points, and Dr. Sachin yet to open the round.
Yeah. So there's a lot of time left in this quiz, and we will move to the 3rd round, which is a diagnostic dilemma. You have to think and you will get the answer. 16-year-old girl, this is for Dr. Kopal, direct question. 16-year-old girl on routine testing, FT4 is 34. TSH is less than 0.001. She has no goiter, no tachycardia, no eye sign. Clinically, you would not say that she has a thyroid problem. She is clinically euthyroid. TRAB is positive. Technetium scan shows a normal uptake, not an increased uptake. So what do you think? Just think over it. It's not a very straightforward one. So high FT4, low TSH, no clinical signs, TRAB positive, technetium scan showing a normal uptake. What is the likely diagnosis or a likely cause here?
There are no symptoms of hyperthyroidism.
No symptoms, nothing at all.
TRAB is positive.
Yeah.
Sir, it can be due to a problem in assay, issue in assay. can be due
Which problem? Yes, yes. Which problem can cause this?
to excessive biotin intake can cause a picture like thyroid
Excellent.
storm.
Excellent, excellent. So this is a perfect scenario. Even TRAP can be positive because most of the assays are biotinidase based. So if you have too much biotin, especially people take it because of hair fall or something like that, that can cause this problem. So this is excellent answer. So biotin effect. So we'll give full marks, and I think this deserves a lot of applause. Very good answer to Dr. Kopal. Next question to Dr. Sachin. 18-month-old boy with adrenal insufficiency, birth weight was low, recurrent infections and anemia, micropenis and hypospadia, low platelet, loose stools. So what is the diagnosis? So this is of course an advanced quiz. So we can have some advanced questions here. So Dr. Sachin?
Pass.
Okay, so this is something you know or you don't know sort of a thing. Dr. Manoj?
Sir, Mirage syndrome, SAM-D9 deficiency.
Oh, excellent. So Mirage syndrome, this has got all the features. I didn't expect this answer so quickly. So there is recurrent infections, anemia, micropenis, hypospadias, low platelet, everything is suggestive of a Mirage syndrome. People get confused with IPEX, which can sometimes cause similar picture. So excellent. 5 points to Dr. Manoj. Next question is direct question to Dr. Manoj. 12-year-old boy on routine screening, TSH is 14, FT4 is normal. He is euthyroid, TPO is negative. He started on L2 thyroxine of 25. FT4 is also high, TSH is also high. And clinically, he is euthyroid. There is no goiter, nothing. So what do you think could explain this, and what would you like to do in this scenario? And somebody stopped.
Sir, it's a,
yeah.
Sir, it's a heterophile antibody interference, sir.
Okay.
If he's having any pets at home and all, he can develop heterophile antibodies that can cause pseudo elevation in TSH in the lab assays.
So I'll give you that. I was thinking more of in the setting of a macro TSH, but okay, this
TSH.
answer is also high.
Pegylation
Right.
can be done.
So both options are right. So I'll give you the marks there. So very good again, Dr. Manoj. Excellent answers there. Next question is to Dr. Anju. 4-year-old boy with failure to thrive, polyuria and rickets. Phosphorus is 1.6, PTH is 34, urinary calcium to creatinine is 0.8, there is hypercalciuria, there is normal blood gas, there is amino acid urea. So, what is the likely diagnosis in a child who has refractory rickets, hypophosphatemia, normalish PTH, high urinary calcium, normal blood gas, amino acid urea? What is the diagnosis and what is the test you would like to do?
Sir, so it is refractory rickets, along with that hypercalciuria and amino acid urea.
Yeah.
So one of the possibilities, sir, could be a Dent syndrome, Dent disease.
Good.
And for that, sir, genetic testing CLCN5 mutation make the diagnosis.
Good. So I'll agree to that. So I was looking at Dent's disease and urine microglobulin, or you can do genetic testing. Both of them are right. So again, very good answers are coming. So this is really going on well. So 10 marks to Dr. Anju. Dr. Salik, your question is 13-year-old boy with diabetes, BMI 30.2, no DKA. He had neonatal hypoglycemia for which diazoxide had been given for few months. And there is a family history of diabetes and obesity. He has mild acanthosis. So what do you think is the likely defect and what is the treatment for this condition?
So it's a form of transient neonatal diabetes now presenting with diabetes.
No, he had neonatal hypoglycemia, not diabetes.
Okay. Sorry.
So, but
so
still
it's a trend
in the right direction.
Yeah. So sulfonylureas, and this is MODY. The same mutation which can cause ABCC8 or KCNJ11 can cause both.
Perfect. So they can cause both. So you can have hypoglycemia and then you will develop diabetes, or diabetes and then diabetes. So both can happen. Excellent answer. So this is ABCC8, KCNJ11 and glibenclamide. Again, excellent answer, Dr. Salik. So 10 points again. Round 3, we have the last question direct to Dr. Sukanya. 17-year-old girl with incidental thyroid nodule, and this is something which is there in the back. It's a very small lesion, 0.8 into 0.6, non-palpable basically, euthyroid, no cervical lymph node, repeat TSH. TSH is normal, nothing to worry from there. What is the likely diagnosis and what will you like to do? So thyroid nodule with a skin lesion. Think that way.
So Carney complex with a thyroid nodule.
It's a bit different. So we will move up to Dr. Sukanya. Dr. Kopal.
Sir, can it be a MEN2 syndrome with MEN2?
Yes, what is it looking like?
Sir, licheniform.
Okay, good. So MEN2 blood test.
Calcitonin levels.
Perfect. So very good answer. So this is actually lichenified amyloidosis, cutaneous amyloidosis, MEN2A, calcitonin. Absolutely right answer. So we have finished the third round. Now the audience question is 18-year-old girl with hirsutism and oligomenorrhea, high testo, PCO appearance on estrogen progesterone, no clinical response. What is the biochemical marker that the drug is working? Anybody in the audience? Okay, so free testosterone, we can do it at the second month of cycle, which will give us the correct clue. So by the time we reach to the round 4, we will have the scores from Dr. Vibha.
At the end of round 3, still Dr. Kopal is leading with 40 points, followed by Dr. Salik at 30 points, then Dr. Anju at 22.5 points, Dr. Manoj at 17.5 points, Dr. Sukanya at 7.5 points, and Dr. Sachin ye 2 point count.
So there's a lot of time left. We have got one full round and then the buzzer round, so it can all change. We will start round 4 again from Dr. Sukanya. So this is about diagnostic dilemmas. 6-year-old girl with type 1 diabetes. She didn't have any DKA. On insulin 0.3 unit per kg per day. C-peptide is 1.2. Drug that can increase the honeymoon phase. Which drug has been shown to prolong the honeymoon phase in type 1 diabetes? And what's the mechanism?
Sir, teplizumab.
Yes, and what does it do?
CD3 blocker, CD3 antagonist.
Perfect. So that's the right answer. So teplizumab and anti-CD3 antibody. Good answer. Full marks to Dr. Sukanya. Next question is to Dr. Salik. So this is more of modern therapeutics. What's new in terms of treatment? 19-year-old girl with recurrent fractures, early onset, persistent despite bisphosphonate. She was discussing with one of her relatives, older relatives, who is now on a non-PTH anabolic therapy. Non-PTH anabolic therapy. So my question is, which drug is an anabolic agent for bone, but it is not PTH?
Denosumab?
No. Dr. Anju?
Sir, enoboparatide, it will be like
It is
PTH
like
receptor.
PTH. So we will, no, we don't look, we're not looking for that one. Dr. Manoj?
Romosozumab.
Absolutely. And this is a?
Sir, it acts on the, I think, cathepsin level. I think.
We'll give you 5 marks. It's anyway a difficult one. So it's actually sclerostin antagonist.
Sclerostin antagonist, yes, sir.
So it's romosozumab. So you will get 5 marks for that one. Now the next question is directly, I think, to Dr. Anju. Okay, so this question is basically, this 10-year-old boy is on Medtronic 780G pump and the insulin adjustment algorithm that they use. What exactly is the principle of this algorithm? What is the name that they use? And I've shown this in the graph.
Sir, it's something PID physiological. I'm not very sure about it.
Okay, so yeah, we'll go forward to Dr. Manoj.
Sir, I think it's a smart card.
Yeah, there is a
technology.
specific name I'm looking at. Dr. Sachin?
PI, proportional integrative derivative.
Excellent. This is what I was looking at. So it looks into how far you are from that particular sugar, how much time will it take, and then you derive. So perfect
Sir,
marks to Dr. Sachin.
Sir, actually, I said the same thing. PID.
You didn't tell the full form.
Okay, sir.
Because we were mainly looking at what exactly this means. So that's why I gave some time, but you didn't come up with the full form. So it's proportional integral derivative. So that is the correct answer we're looking at. Dr. Manoj,
Yes, sir.
15-day-old girl with hypoglycemia, birth weight is 3200 grams, GIR is 14 milligram per kg per minute, ketone is 1.1. There is a homozygous ATP defect advised for pancreatic surgery. There is a new rescue therapy which has been developed which can prevent surgery for some time at least. And this child is not responding to octreotide, lanreotide, everything. Yeah.
Diazoxide can be. Right.
No. Diazoxide is refractory in this case. Dr. Sachin?
Azathioprine?
No. Dr. Kopal? I'm looking at a very specific agent.
Dasiglucagon.
Absolutely right. So dasiglucagon is an agent which has been used as a rescue therapy. There's a recent trial which was published which shows that. So perfectly correct answer. So 5 marks to Dr. Kopal. We are coming now for the second last choice for Dr. Sachin. 2-year-old girl, rapidly progressive obesity, hyperphagia, weight is 24. There is a leptin receptor defect which was found in this case. Novel option. And what is the benefit of that modification which was done in this drug? Dr. Sachin?
So metrolleptin?
No. Dr. Kopal?
So setmelanotide, MC4R agonist.
And what is the benefit of using this modification?
I'm not very sure, but as far as I remember, it acts specifically on MC4R receptor, not on other.
No, but what is the effect of MSH? If you think of effect of MSH, you will know that what can it want to prevent?
No hyperpigmentation with that.
And cardiac. So it doesn't cause palpitation, other things. So I'll give you the marks for that. It is setmelanotide, which is used for POMC defect, proconvertase defect, leptin receptor defect, all those scenarios. So it's setmelanotide. Again, the correct pass to Dr. Kopal, 5 marks there. We have the final question. 14-year-old girl with type 1 diabetes going again to Dr. Kopal. Basal bolus regimen. BMI is 18. High post-meal excursion. Always her post-meal reading the very high. HbA1c is 9.5. There is a very, very recent publication of a new non-insulin drug which may help in this post-prandial excursion. So these are all about the novel developments, especially targeting the post-prandial. If you think about it, you may get the right answer.
So GLP-1 analog, not sure.
No, we are not looking at that. Dr. Sukanya?
Sir, amylin analog.
Amylin had been there for a long time. They have not been found to be very helpful. But okay, we'll carry forward Dr. Salik.
Is this empagliflozin?
No, not empagliflozin. Dr. Anju?
Not sure, sir.
Dr. Manoj?
Sir, maybe acarbose or oglibose.
No. They have been there for a long time. They cause more of global warming than any other benefit in the time of overall improvement. Dr. Sachin? There's a very specific drug I'm looking at.
No.
So we talked about dasiglucagon. There is also a glucagon antagonist which has recently been studied, which has been shown to improve the postprandial excursion in type 1. This is volagidimab. This is a newer one. So this was, of course, wanted to be a very latest sort of a question there. For audience question, 2-week-old preterm neonate, calcium is 14, phosphorus is 1.8, PTH is low, vitamin D is 20, calcitriol is high. Which therapeutic strategy could help in this scenario? What was the problem in this case? No, the phosphorus is low. So we'll see what people are answering. So this is basically that there was less amount of what is happening here, Alapan? No. You had given less amount of phosphorus supplement. So when the phosphorus supplement is low in preterm who are on TPN, the calcitriol becomes high. They develop hypercalcemia. So you should give phosphorus supplement. So round 4 scores, Dr. Vibha?
At the end of round 4, still Dr. Kopal is leading with 50 points, followed by Dr. Salim at 30 points. Dr. Manoj and Dr. Anju has 22.5 points, followed by Dr. Sukanya at 17.5 points, and Dr. Sanchin at 5 points.
Okay. So we are moving towards the final round, which is a buzzer round. So again, 30 points can be gained. So at least all 3 people are in contention. They can get 30 points and they can go. So I think all of you can go. Dr. Anju and Dr. Manoj, I think both of them have an option to become number 1. Dr. Vibha? So Dr. Anju and Dr. Manoj both have a chance?
Yes.
So to get 30 points, so all 6 right, you will get 30. All 6 wrong, you will get minus 30. So this is a buzzer round. Buzzer round again, the chat will be reset after every question. I'll write N, then you have to write the buzzer. I'll stop the question there. Immediately you have to answer 5 for correct and minus 5 for the wrong answer. So I am going to start with the chat option and I am going to write N. All of you can write Y just to make sure that your thing is working. Dr. Kopal, Dr. Sachin, Dr. Salik, Dr. Sukanya, Dr. Manoj. I couldn't get from Dr. Manoj. Dr. Manoj,
yes, sir, it was coming, I think. Yes, sir, I am there, sir. In chat box, I am writing, sir. It is coming at to Dr. Sukanya, it is coming.
You
Yes,
write host and
minute,
panelist.
to host.
Host and panelist. Everybody
One
make it
minute,
host
sir.
and panelist.
Now it came, I think, sir.
Yeah, it came now. So I am going to reset it now and we will start with the question. So don't just look at the full question and then go come on to the answer. So the first question is 14.5-year-old boy with delayed puberty, family history in father, height is 148, weight is 45. Dr. Salik has pushed the button. What is the most, you tell me, what is the answer, Dr. Salik?
Inhibin.
Inhibin B.
Yes, sir. Inhibin B.
What do you think? We should give the answer? Actually, we were looking for something more specific, which is FSH stimulated inhibin B.
Stimulated
But
inhibin
give you
B.
the answer. So we'll give you +5 there. Dr. Salik. Next question. I am going to reset. So be ready for the next question. It is 1-month-old term baby with lethargy, weakness, TSH more than 100. Screening TSH was 3. There is no dysmorphism, no hospitalization, no prematurity. What is the possible cause of this? Dr. Manoj?
So maybe TSS receptor blocking antibodies crossing the placenta.
No, but why at 1 month the TSH is gone up? It's the other way around. The initial TSH is normal. That means there is a false negative screen. So what I was looking at was twin-to-twin transfusion. So -5 to Dr. Manoj. I'm going to reset it again. So next question is 14-year-old girl with bipolar disorder, polyuria, polydipsia, serum sodium. Dr. Manoj?
Sir, we can give thiazide diuretic.
Okay, so this again is a very
Sir, sir, actually, is my Y shown to you or not? I felt.
We can give either amiloride or the thiazide diuretic.
Which one? You choose one.
Amiloride.
Amiloride is specific one because that is the one specifically which is there for the epithelial sodium chloride channel. Dr. Anju, we saw your Y initially, but we are not seeing it now. Are you writing to host and panelist or to something else? Right? Once more.
Sir, I write it in chat box.
Yeah, everything is in the chat. Just try to
Because
write.
sir, I write it, I think 2 times, but
It's not coming now. You can write it once more. Just let me see.
yes, sir.
You write
Now I'm
host and
not.
panelist.
Okay,
The
sir.
options are host and panelist. You might be writing to somebody individually, maybe by error.
Sir,
Everyone you can write.
Okay, sir. Where to change that?
In the chat box, there is one. If you can see this one, there is a everyone. You are seeing this Zoom in this stream. In Zoom, in the chat box, there is an option, everyone, host and panelist, and then you have individual names.
No, sir.
You pull down you open the chat.
Yes, sir. I opened the chat.
There is an option 2, where the options are everyone. Lower part of the chat, where do I type the message?
Sir, I'm typing, but that everyone option, I'm not able to.
Yeah, you can, I'll share the entire one. Can you see the screen now?
Yes, sir, I can see the screen.
You can see the Zoom.
Yes, sir.
There is a chat here. Now a chat pop-up is there. There is a everyone here.
Sorry, sir. Now I'm not able to see the Zoom.
What can we do? You open the chat, there is an option to whom you can send the messages.
That option I'm not able to find out. Actually, there are 3.
I'm sharing the screen, full screen. You can share your screen. You can share your screen and show us.
1 second, sir.
Can you go to Zoom? Can you stop the website? Okay, your Zoom, can we see the Zoom? Meanwhile, what is the current score after 3 questions? Yeah. So at the moment, we have got Dr. Kopal, who is at 50. Dr. Sachin is at 5. Dr. Manoj is at 22.5. Dr. Anju is at 22.5. Dr. Salik is at 35. And Dr. Sukanya is 17.5. So can you open the Zoom? And here you go to chat.
Sir, I'm not able to open Zoom actually.
So how are you answering then? नहीं वो तो अपना है. This is ours. In the screen we can't see. Okay, so it's difficult. How do we go answer that? You're able to see the questions and everything.
Sir, can I log out and log in again? In that way it will work, sir.
But you need to have a look at the Zoom. Try to do it quickly.
Sir, I'm trying to open the Zoom, but that is not opening.
Okay, so you can just try to log off and come again, maybe.
Okay, sir. I'll try that, sir.
We had done what 3 questions more, no? So Dr. Anju has joined back. So we have 3 more questions left, and still there is chance specifically for the people to, at least for the second page, there is a big tie which is going on. Can somebody call her or something? Prashant ke paas might have the number. So will it make a difference now for this sort of a marks? And for second?
There is a way to take control of the answer screen also.
Okay. नहीं उनका. So we'll wait for a couple of minutes. If it does not work, we will continue with the quiz. So just hold on for a couple. Dr. Anju is back. Dr. Anju?
Sir,
Are you seeing the chat now?
sir, I'm seeing the chat now. I'm typing it.
Yeah,
Is
yeah,
it-
we are getting it now.
Okay, sir. Okay,
So
sir.
you've got 3 questions. If you get all 3 right, you can be number 2. That's what we can guarantee from here. Can anybody become number 1? No, Dr. Cooper is anyway number 1. Like, is anybody can overcome or not? So there is, Dr. Salik can still go to number 1. So it's an interesting round going on. So there are 3 more questions, and I'll not share the screen. And in the chat, we are going to reset. I'm going to reset. So we go for the next question. 4th question, just 3 more questions left. 11-year-old girl with type 1 diabetes, diagnosed 8 years of age, insulin 1 unit per kg per day, visual complaints, retinopathy, GAD negative, which is a likely defect. Dr. Sukanya?
Sir, DIDMOD.
And Jean?
WFS1.
Okay, perfect. So you will get the right answer, 5 marks for that one. I am going to reset it again. The next question is, second last question is, 12-year-old boy with polyuria, urinary osmolality is 120, water deprivation suggests central DI, CSF blood HCG calcium is normal. This is the MRI picture. Skeletal survey is normal. Which test makes germinoma unlikely? Dr. Manoj?
Sir, if we do LH, if it is not suppressed, then it is not due to germinoma, sir. Because in germinoma HCG is high, LH may be suppressed in that thing.
This is slightly different.
Serum
So
LH.
this germinoma may not really be secreting HCG in this case because HCG is anyway normal. So if we are looking at a very specific one. So this is basically a rapamycin 3A antibody, which is, so this, we will not give -5 because that option is also not wrong, but we will not give +5. So this was a bit of a option, but that logic is good that if your HCG is high, your LH should be low. But because here HCG was also low, so we would be a bit wary on that. So now we have got, I think, just one more question. So what is the current status, Dr. Vibha? So before the last question, I think Dr. Kopal is already at 50, so she is quite safe. Dr. Salik is also safe at 35. Dr. Anju and Dr. Manoj are there at 22.5 each. Dr. Sukanya is also at 22.5. So the fight is mainly for the third plus spot. So let's see whether those people will be able to, who will become that part. So I'll reset it once more. And we have the last question which is coming up. 4-week girl with atypical genitalia, inguinal gonads, no uterus, karyotype is XY, testo is low, LH is 5.2, sodium potassium is normal, most likely cause. Dr. Sukanya?
Sir, HSD 17B3 defect.
HSD 17B3 defect. Okay. Anything else? LH is specifically high.
Like LHCGR can also be one of the differentials.
Okay, so I'll give it to you. Predominantly, I was looking for LHCGR, but 17 beta HSD can also cause a similar one. So good, you have jumped up to the third spot. So that's I think the last question before the time we get collate all the answers and everything. We have a question for the audience. 18-year-old girl with amenorrhea, galactorrhea, low LH, low FSH, TSH is 3.2, prolactin is 34. There's a large lesion here. What would you do? So you do basically it could be a hook effect. So you should do a repeat after dilution. So what are the final scores, Dr. Vibha? You can announce the winners.
The final score is congratulations to Dr. Koma. She gets first position with 50 points. And second place is secured by Dr. Salik with 35 points. And Dr. Sukanya, you have made it and you have got 27.5 and you have secured the third position. Congratulations.
So thank you, Dr. Vibha. And it was a very interesting quiz because all of you, the question levels were quite tough and you were able to crack most of them. So we'll start off with the feedback. So we'll start with Dr. Sachin.
It was a very good learning experience. It was a very enjoyable experience.
Thank you. And then Dr. Manoj?
Yes, sir. It was a good experience to know new drugs and novel therapies, etc.
Thank you. And then we will have feedback from Dr. Anju. Unfortunately, there was some buzzer issue, I think. Yeah.
Yes, sir. Definitely, it's a very good learning experience, and the newer advances that is quite stimulating. And
we deliberately wanted, because this was the advanced one, so we wanted to focus on those parts. Dr. Sukanya?
So this was a great learning experience.
Dr. Sachin? I think Dr. Sachin is not there. Dr. Kopal, congratulations.
Thank you so much, sir. So it was obviously a very good learning experience. And I've been learning, I don't know from how long from you, through your videos and through your classes. Thank you so much, sir.
Thank you. Thank you. I think Dr. Salik is left. Dr. Salik is there?
Yes, sir.
Yeah.
So thanks.
Congratulations, Dr. Salik.
Yeah, thanks for conducting this wonderful session, sir. It was very much informative.
Thank you. Thanks. And once again, thanks all of you for being such a good sports, for performing both in prelims here. And we've got a lot of audience here as well. Thanks all of them and all the team, Dr. Alappa and Dr. Sandeep, Dr. Nimisha and Dr. Vibha. So we'll close the session and we'll have the annual